Okay, knee assessment. Now we could talk about the ins and outs of the knee all day long, but we're going to try and break it down into 3 key areas to make this assessment nice, quick and efficient, and get the patient along the right pathway as soon as possible. So we'll talk about the ligaments, the meniscus or the cartilage, and the patellofemoral joint. Just before we do though, if we touch on osteoarthritis of the knee, the key indicators will come from kind of the subjective assessment, morning stiffness, are they getting pain on walking, stairs, that sort of thing. To assess it objectively, we're going to look at our active range of movement and our passive range of movement. Okay, so first off, we can get Rob, patient, lying on his back. So we're going to look at flexion and extension of the knee. So if we can get Rob just to bend his knee up as far as you can, slide your heel to your bum there. Good. And we're looking at how far it can go. We'll obviously compare it to the other side. And then if you can straighten it out for me as far as you can. Good. And then if you can just try and squash my hand down into the bed there. Okay, so we're looking to see whether we can get the full extension there. If you didn't have his full active range of movement, so if you just take it up a little bit there for me, and you've got restricted and a bit of pain there, then what we then need to do is assess that passively. Okay, so if I come round, drop that one down for me. So to assess the knee passively, we're just going to take it through that range of movement. Now what we're looking for is, does the passive movement equal the active movement? Is there pain? Is it restricted? Is there a stiff end feel? Okay, if passively the leg's fully offloaded and we can take it the full way, then it's more likely that pain is restricting it rather than a structural pathology, so that might rule out osteoarthritis. If passively we're restricted as well and the patient's in quite a bit of pain, we might not be able to get it into full extension. We can then have a little palpate around the joint line. Okay, so we can palpate medially along the joint line, or we can palpate laterally along the joint line. Okay, and again, remember to assess both sides. If that adds up with their age, their aggravating factors, the fact that there's a stiff end feel and we're structurally limited there, then we can consider osteoarthritis as a diagnosis. If that's the case, we need to send the patient for an X-ray, and if moderate or severe arthritis is established, then you can refer them onto our structured knee assessment pathway. If there's some mild arthritis, then refer them into or get them to self-refer to our normal physiotherapy service, where we can begin sort of knee rehabilitation. Okay, so that's ruling in or ruling out osteoarthritis. So if we move on to our 3 areas now, if we take the ligaments to start with, there's kind of 5 main ligaments we need to consider around the knee. Okay, you've got your ACL, your anterior cruciate ligament, your PCL, your posterior cruciate ligament, your LCL, which is your lateral collateral ligament, your MCL, which is your medial collateral ligament, and your MTFL, which is your medial tibial femoral ligament. With a ligament injury, there needs to be an injury. Okay, there needs to be a deceleration, so the patient's slowing down, or there needs to be a twisting movement to cause that ligament to strain or tear there. If there isn't, then there isn't likely to be a ligament injury there. Also with the medial tibial femoral ligament, the patient will have experienced a dislocation. They might have witnessed the patella moving. They might have that kind of clicking, locking back into place sensation, that sort of thing. So they're the kind of subjective markers. To objectively assess our ligaments, if we start with the ACL, okay, so the anterior cruciate ligament, just bring that one down for me there. We're going to do what we call an anterior draw test first. Okay, so just sliding the knee up into this position, we're going to come round, pop ourselves on the foot of the patient there. What we want to do is we want to make sure the patient's nice and relaxed. Okay, so the hamstring muscle at the back can act similarly to the ACL ligament. Okay, so we want that nice and relaxed. Then what we're going to do is we're going to feel for the joint line, okay, where the tibia is. We're going to apply pressure on the back of the tibia, on the back of the shin bone, and try and pull it forwards essentially, okay? And what we're looking for is any anterior translation, any forward movement of the tibia on the femur, okay, of the shin bone on the thigh bone. And you must compare both sides, okay? The second test we can do for the ACL, for the anterior cruciate ligament, is the Lachman's draw test, okay? So if I get you to straighten that one out there, I'm just going to come round on this one. Now, for this one, we want to place our knee under the patient's thigh, okay? Again, making sure the knee's nice and relaxed. Using one of our hands, we're feeling for that joint line again, okay? Coming around the back of the tibia. And what we want here is a nice short sharp movement, force on the back of the tibia, force on the back of the shin bone, and we're pulling up nice and quick, nice and sharp. And again, you're looking for any anterior translation of the tibia, any forward movement of the tibia on the femur, the thigh bone. And again, you must compare both sides to get a feel for the non-injured leg as well. So that's the ACL, the anterior cruciate ligament. To assess the PCL, the posterior cruciate ligament, okay, first thing we're going to do, okay, is simply just look, okay. So we're going to bend the knee up into 90 degrees, okay. I'm going to support it at the ankle, and if there's an injury, if the posterior cruciate ligament is torn, then you're going to get a drop of the tibia, okay, a posterior translation of the tibia. We can see there, obviously we haven't. Again, make sure you compare both sides. You can also do a bit of a posterior draw test. So in exactly the same position as we did the anterior draw, again, feeling for sort of joint line, what you're going to do is just apply some force on the tibia from the front, okay? And again, you're just feeling for any posterior translation, any backwards movement of the tibia there. If we want to assess the collateral ligaments, okay, so you've got your lateral collateral ligament and your medial collateral ligament, we can do a varus and valgus strain test. Okay, so if we're testing the medial collateral ligament first, we're going to take the knee up into 30 degrees, make sure it's nice and supported, okay, and what we're going to do is we're going to apply a valgus stress to the tibia, okay, so we're looking to move the tibia outwards, laterally, whilst stabilising, keeping the femur, the thigh bone still, okay. So we're applying force across, we're looking for any laxity in a first instance, and any reproduction of pain. And then we're obviously going to compare it to the other side, so we get a feel for the non-injured leg as well. Vice versa, if we're testing the lateral collateral ligament, we want to apply a varus stretch, okay. So for this one, I tend to get the patient to take that knee up to 30 degrees, and come round, knee nice and supported, we're again fixing at the femur. This time we're applying pressure in a varus form to the tibia, so we're trying to take the tibia inwards, okay, medially, and again we're looking for any laxity in a first instance, and then any reproduction of the patient's symptoms, okay. And again, we compare both sides to get a feel for the non-injured leg. So the final ligament we're going to assess is the medial tibial femoral ligament. Now, I'd only really assess this ligament if the patient had experienced a dislocation, they'd witnessed the knee popping out as such, or they'd had that feeling of popping, clicking, that sort of sensation. And all we're going to do is we're going to glide the patella laterally, and what we're looking for here is sort of apprehension, pain. If the patient has experienced a dislocation, they won't want you to do this, they won't let you to do this, there'll be real apprehension there, okay. So just with your thumbs over the sort of medial border of the patella, and you're just gliding it laterally, okay. And as I said, the patient will be very apprehensive about this if they've experienced a dislocation with damage to this ligament. Okay, so if we found one of those tests to be positive, then depending on kind of the patient's goals, where they want to get back to, is how we place them on sort of the pathway. But it's generally considered, because of the risks of surgery, that conservative management should be the first option. So either refer to physiotherapy or get the patient to self-refer to physiotherapy. We can do a good structured assessment and get them on the rehabilitation pathway. Okay, start to build up the knee again to what they want to do. If we check all the ligaments, it's not a ligament problem. We can move on to our sort of second category of knee pain, as it were, and that's the meniscus or the cartilage. So there's kind of two ways we can sort of injure our meniscus. The first one is similar to the ligaments. There'll be an injury. Okay, so there'll be a twisting injury, usually on a flexed knee, and the patient's twisted. Or alternatively, we can have a degenerative meniscus as well, as opposed to a traumatic meniscus injury. These typically occur in your patients that maybe sort of over 35. They might do repetitive movements, and we can get a bit of a degenerative tear there as well. Okay, these type of injuries, meniscal type injuries, will be accompanied with sort of locking of the knee, maybe in a fixed flexed position, some giving way at the knee, or some clicking, clunking, popping, that sort of those sort of symptoms there. Objectively, we tend to work through sort of 3 tests to highlight the meniscus. Neither are sort of very specific or very sensitive on their own, but if we group them together, the sensitivity and the specificity for diagnosing such an issue becomes a lot better. So the first test we're going to do is what we call a modified McMurray's test. Okay, we're going to take the knee up into full flexion and apply some external internal rotation forces. And again, we're looking for reproduction of the patient's symptoms, or any clicking, clunking, popping, those sort of symptoms. So what we're going to do, just to assess the knee, we're going to first take Rob's leg up into full flexion. Okay, and then from that position, we're just going to externally rotate the tibia and then internally rotate the tibia. Okay, see if that reproduces any symptoms first off, and then we're going to hold the knee into external rotation, and we're going to take that leg through extension and flexion. Again, looking for any clicking, clunking, popping, any reproduction of pain, and then we're going to do internal rotation, take it through the same extension and flexion movement, and compare both sides. Okay. The second test we'll use is just palpation of the joint line, palpation of the meniscus there. So we can go laterally or we can go medially, sort of along that joint line, see if that reproduces any pain. Okay, so the final test we're going to do for the meniscus is called a Fesley's test. So if we can get Rob standing up for me, I'm just going to come round. Okay, so we're going to have Rob standing on one leg. Okay, I'm going to take my hands for balance there. Okay, we're going to get him to bend his knee. Okay, approximately sort of 30 degrees, that sort of range. Rob, I want you to keep your foot in one place. I'm just going to move you around. Okay, so again, we're doing an internal external rotation at the knee, but in a weight bearing position this time, and we're looking for any reproduction of the patient's symptoms. Good. And back round. And then if that doesn't bring on the symptoms at all, you can take him into sort of 60 degrees of flexion and retest in there. If you find that they do have a meniscal injury, whether that be a traumatic meniscal injury or a degenerative meniscal injury, again, first line of treatment is conservative management. Okay, if they're truly sort of locking, clicking and clunking, then we may need an orthopaedic opinion, but the kind of research now points towards conservative management for around about 6 months because of the risk of surgery, risk of arthritis in the future and such. A good structured strengthening program, slowly building back to normal activities, is the best line of treatment. So discuss this with the patient, give them the time frames. Generally takes sort of 3 to 6 months to settle down with a good structured program, and either refer them to physiotherapy or get them to self-refer. Okay, so the final area of our knee assessment is the patellofemoral joint. So the joint between the patella the kneecap, and the thigh bone, the femur. Now this will generally be your patient who comes in who's not very specific about the pain, sort of diffuse area of pain, they're not really sure where it is. Whereas with the meniscus, they're generally sort of quite, oh, the pain is here. With patellofemoral pain, they'll be a bit non-specific. These are generally caused by sort of overload or perhaps underload as well. So the patient might have been doing something a bit different. They might have started running, or they might have increased their distance. They might have started a new job where they're on their feet all day, or they might have started walking a little bit more, those sort of things. Or alternatively, they might have stopped doing everything for a period of time and be slowly getting back into it. So sort of underload, overload stuff there. So to assess this, we're going to go through a couple of weight bearing assessments and then a couple of assessments on the bed. Okay, so the first test we'll use is a squat. Okay, so it's a weight bearing position, we're loading the knee joint. There's lots of different things we can look at during a patient squat. For you guys, we're just looking to reproduce that pain. Is it around the kneecap? Does it feel like it's under the kneecap? Those sort of descriptions. So all we're going to do is get Rob to stand feet shoulder width apart, and you're just going to squat down for me as far as you can. Good, and again. Good. So we're just simply looking for that reproduction of symptoms in and around the kneecap there. If not, I would go on to a single leg squat. Okay, so I'd get Rob to stand on one leg, and again just squat down as far as you can for me. And again. Good. And we're just seeing if that reproduces any symptoms. We're looking for the control of the muscle structures around that kneecap, so the kneecap's nice and stable, not causing any pain to the structures that sit beneath it. The first test we'll do in line for the patellofemoral joint is just what we call a compression test of the patella. Okay, so first off, we're just going to come centrally on top of the kneecap and apply some pressure. Then we're going to go above, below, and either side. And all we're doing is looking for the reproduction of symptoms. Are we irritating any of the structures that might have become a bit irritated, a bit inflamed, sitting beneath that kneecap there? Then the final test we can do, okay, is if we apply a bit of pressure over the top of the kneecap. This is called a Clark's test. What I'm going to do is just ask Rob to contract his quadricep muscle. So push his knee down into the bed and then relax. And again. Good, and relax. And again, all we're looking for is the reproduction of symptoms. Okay. If those tests are positive, the patient's got the subjective sort of markers, overuse, lots of standing, being on the feet, that sort of thing, and these tests are positive, then they need a good structured rehabilitation program to retrain the quadricep muscles, to retrain the gluteal muscles, to get the control around the knee so that those structures don't get irritated anymore. So talk them through that and then refer them to physiotherapy or get them to self-refer to physiotherapy. I would also just recommend that they avoid aggravating activities for the time being and allow us to sort of guide them through a gradual progression back to their normal activities. Good. So just to summarise, first things we're clearing is sort of osteoarthritis of the knee. So think about the patient's age, think about whether they're getting the sort of morning stiffness, pain on walking, stairs, and assess their active and passive ranges of movement. Okay, if they're restricted and painful, they meet the age, get them x-rayed. If it's confirmed as sort of moderate or severe, refer them through to the structured knee assessment pathway. If it's mild arthritis, then sort of the usual physiotherapy service, get them to self-refer. If they've had an injury, so it's a deceleration injury or a twisting injury, then there's a potential for ligament damage there. Okay, go through the assessments of your sort of anterior cruciate ligament, your posterior cruciate ligament, lateral and medial collateral ligaments, and if they've had a sort of feeling of dislocation or they've witnessed that patella coming out, then test the medial tibial femoral ligament as well. If they've had a sort of twisting injury, maybe on a bent knee, and all the ligaments are clear, then test their meniscus. So modified McMurray's, joint line palpation, and Fesseli's test. Remember, you can also get degenerative meniscus, so those patients that might be over 35, do sort of repetitive work, lots of bending and extending at the knee, might also have those positive tests. Best course of action for ligament and meniscal injuries is a good period of conservative management, structured rehabilitation to rehab the muscles around the joint and get the knee stable again. And generally we're looking for sort of 6 months or so. Final thing is that kind of non-specific diffuse pain around the knee. Patient's not really sure where the pain is coming from. They might think it's sort of around the kneecap, might be a bit behind the knee, might be under the kneecap. Then do consider the patellofemoral joint as a source of pain. Run through some weight-bearing assessments, squatting, compress the patella, have a feel around there. And again, what they need is a good structured rehab program, rest from aggravating factors, and good progression back to their normal activities. So either refer them to physiotherapy or get them to self-refer.